So, we have a good grasp on VP shunts, G-tubes, and trachs. We're all settled when it comes to the high-tech kid in the ED, right? Well, if it were only that simple. Technology is always pushing the boundaries, and we feel that push in the ED more than anyone because although technology has allowed these children to live longer and live at home, if there's a problem, they're coming right for us. Let's take our tech savvy to the next level with a play-by-play on vagal nerve stimulators, baclofen pumps, and left ventricular assist devices in children and adolescents.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Children who are technologically dependent have special needs: physical, medical, and psychosocial. Meeting those needs can be a challenge. Make the caregiver your ally and really get to the bottom of his or her concern. She knows the child best. All right, you know your way around the basics of medical devices, but today we'll go over the less frequent ones. The goal is to be familiar with the emergencies associated with them. Even if the child with the device ends up being fine and today's visit doesn't end up being related to the device, parents sense your level of familiarity and comfort. Just being aware of what the child has implanted in him goes a long way to building rapport and collaboration. Your background knowledge itself may be therapeutic. And it doesn't hurt to know your way around the hardware. Liam is a 5-year-old boy with Landau-Kleffner syndrome, language delay, and epilepsy. He's brought in by his mother for not acting right. Liam had been in his usual state of health until that afternoon when he just seemed less responsive to his mother. Sometimes he just doesn't listen, said his mother. This time was different. Landau-Kleffner is also called acquired epileptic aphasia. It's a terrifying diagnosis. The infant grows and develops normally, develops language normally, and just when he's running around the house, talking your ear off like a big chatterbox, getting ready to go to kindergarten, he starts to decline. He becomes frustrated again at expressing himself. He doesn't recognize familiar sounds, and his language, especially his expressive language, just fails him. He begins to have seizures, especially at night, that can then progress to daytime hours. There is substantial variability in patients, but most have epilepsy and many have refractory epilepsy. It turns out Liam has been on multiple anti-epileptics with poor response. Liam's been having 4 to 6 seizures per day. Last year, he had a vagus nerve stimulator, a VNS, implanted. The vagus nerve stimulator is kind of like a pacemaker for the brain. A pulse generator is surgically implanted in the subcutaneous tissues of the left chest, and a wire is burrowed under the chest up to the anterior triangle of the neck. You'll see another incision at the neck where the left vagus nerve is accessed in the carotid sheath, and the electrode is fastened on the spaghetti-like left vagus nerve. The VNS works in mysterious ways. The practical use of it was discovered before the chemical neuroanatomical basis was better understood. Here's a summary. Impulses are sent up the vagus nerve into the solitary nucleus in the medulla, where it has further extensions into the thalamus, your brain's information hub, the hypothalamus, your neurohormonal regulator, and the locus coeruleus, your brain's attention and arousal on-off switch. The VNS works by direct stimulation and neuron firing, as well as indirectly by mediating the release of GABA, serotonin, and norepinephrine. With his VNS, Liam's seizure frequency has been cut in half, and his family seems to be doing better as well. Liam's vitals are normal. He's sitting in his mother's lap, but hunched over, apparently staring into an empty corner. You kneel down to his level and gently try to interact with him. He really has that 1,000-yard stare. You see that he's not tracking at all, even with hand-to-face confrontation. He's seizing. Liam's mother is a bit nervous in general about the whole situation, so without upsetting her, you carefully take Liam's hand. You noticed earlier he was wearing his wristband that houses the VNS magnet, and you swipe his wrist magnet over his chest. You wait a minute. He breaks his stare and begins to whimper and fidget. You broke his seizure by resetting the VNS with his magnet. The VNS works like this. At baseline, it sends an afferent pulse up the vagus nerve into the corona radiata for 30 seconds at a time at 5-minute intervals. By passing the magnet over the chest, you force the VNS to kick in again now. The proper way to swipe is over the chest over 1 second. You can repeat in 1 to 2 minutes if you don't see an effect. Conversely, if the child is having symptoms that he can't tolerate acutely, perhaps uncontrollable coughing or hoarseness or pain or nausea or headache, all of which are very rare, by the way, you can always tape the magnet over the chest wall over the pulse generator. After 6 seconds, the VNS will turn off and will stay off as long as you keep the magnet there. You almost never need to do this, but it's good to know that you can disable the VNS if you need to. Amy is a 10-year-old girl with spastic diplegic cerebral palsy who was found in her bed unresponsive by her mother. She arrives by ambulance now. Amy is unresponsive to verbal or painful stimuli, but she's breathing and has an intact gag reflex. There's no evidence of trauma. She doesn't feel particularly hot or warm. Her breath sounds are bilateral. Her abdomen is soft. She has good perfusion throughout without bruising or petechiae. Heart rate is 62, blood pressure 102/56, respiratory rate 12, and she has a normal oxygen saturation and temperature. Mother comes rushing past the paramedics, frantic, at first unable to answer your questions. Amy is not on any medications except for her baclofen pump, which was implanted 2 years prior. It's typically refilled every 3 weeks and was filled last week without any event. Mother does note that they have been steadily increasing her basal rate because she was growing and she needed more of the medicine to have the same effect. This is all important information, but certainly Amy's differential diagnosis is broad. Could this be meningoencephalitis, sepsis, spontaneous intracerebral hemorrhage, or some other cause of the change in her mental status? You re-examine her. Nothing. So you scan her head. Nothing. Really, she looks like she's just profoundly drunk. But she's only 10 years old. But wait a minute. Is it the baclofen? What do you do now? Intrathecal pumps are a godsend to people suffering from spasticity due to cerebral palsy, multiple sclerosis, traumatic brain injury, or spinal cord injury. We're seeing these in children and in adults alike. Spasticity is painful. It's disturbing. And most importantly, it's disabling. What happens in these disorders is that the normal balance between excitatory and inhibitory impulses is disrupted because of an upper motor neuron lesion. Baclofen is structurally similar to GABA. If you deliver baclofen directly to the spinal cord, you can avoid the profound systemic effects it has by the oral or intravenous route. Baclofen works on the monosynaptic reflex arc at the level of the spinal cord to dampen the spasticity. The goal is not flaccid paralysis, simply a rebalance of excitatory and inhibitory activity. This leads to a much improved quality of life for most people who use intrathecal pumps just to function. The problem is the hardware. It has a motor. It has to be refilled. It's implanted in an area that can be open to mechanical forces, to damage. In a study by Ghosh et al., pump or catheter failure was found in 20% of subjects. Really, in practice, intrathecal pumps will cause you grief in the acute setting because of one of three things: the catheter, which can tear, leak, or migrate; the pump, which can malfunction or get infected; or the patient. Basically, he can cause a type of twiddler syndrome that we see in pacemaker patients. You should also think about something called micro-leak syndrome when you see a child or adult complain of a variety of symptoms that change during the day. When supine, the pump directs medicine against low-flow CSF pressure, about 10 centimeters of water. When upright, CSF pressures, especially with spasticity, may reach as high as 50 to 70 centimeters of water. This high CSF pressure can create backflow into the catheter and pump, causing less medication to be administered or causing leaking of the medication through a microscopic rent in the catheter system. The result is good spastic control when supine, but less medication given when upright. Since a micro tear may not show up on a dye study, the first screening test is to elicit by history or by demonstration postural changes in baclofen administration, which can be easily shown bedside in the ED. All right, back to our barely breathing Amy. She's actually maintaining her airway, but she's relatively bradycardic. She's intoxicated with the substance that really doesn't have an antidote. What do we do now? Well, we do what we always do when we're tasked with a complicated situation in emergency medicine. We stay true to our principles and prioritize. What's the first thing to do when a patient is poisoned or overdosed? Stop the offending agent. The magic phrase we hear over and over again is often moot because the sequence of events that brought the patient to you is over and you're left with the consequences. Here, though, with an intrathecal pump, it's different. She continues to receive supratherapeutic doses of a sedative hypnotic that has already had profound effects on her cardiovascular system and may later affect her breathing. We need to decontaminate her. In an ideal world, the physical medicine and rehabilitation specialist is right there with you with his or her handy-dandy laptop and programmer, and she can interrogate the pump and instantly know the dose programmed, the dose delivered, and more importantly, she can shut it off. Sometimes neurosurgeons have access to these. It never hurts to ask. But back to the bedside. There are two things that you can do now: vacate the pump or perform a large volume lumbar puncture. To vacate the pump of baclofen, use aseptic technique, clean the site, stabilize the pump with your non-dominant hand, and palpate the center of it to find the depression where the silastic membrane is. If you have access to a refill kit, sometimes a parent has one, or you can wrangle one if you ask around, there is a sterile plastic template that you can place over the pump, and it guides you exactly to where you need to aspirate. Use a 25 gauge Huber needle, or if you have to, a 20 gauge butterfly needle. Aspirate as much as you can. The pump has a safety mechanism in it, and if the reservoir runs low, it will start to beep, then shut off the pump. So you don't actually have to aspirate all of it out for the motor to stop. You can also use ultrasound to try to find where the sweet spot is of the silastic membrane. Dr. Yang et al. In the Journal of the International Society of Pediatric Neurosurgery described a method for using ultrasound to access the port. The authors show how to fill it, but they can also use a technique. Dr. Yang et al. In the Journal of the International Society of Pediatric Neurosurgery described a method for using ultrasound to access the port. Links are in the show notes. The second option is to do a lumbar puncture and draw off more than you normally would, up to 20 mLs of CSF. The idea is to get the drug off the patient and allow him to renew his CSF stores and dilute the drug. As a temporizing measure, and if your patient is doing poorly, you can stave off intubation temporarily with a small dose of physostigmine. Dr. Muller reported a case series and proposed a protocol drip. Give 0.02 milligrams per kilogram of physostigmine to a maximum of 2 milligrams over 3 to 5 minutes. You can repeat in 15 to 20 minutes. Physostigmine is a cholinesterase inhibitor, so you'll remember if you've ever given a test dose to a myasthenic patient, you can precipitate cholinergic syndrome. Be ready for bradycardia and all the other dumbbells. There are also case reports of using atropine or even hemodialysis for baclofen overdose. The main thing is to get that pump off by evacuating it, pulling off a large amount of CSF, or ideally reprogramming it if you have that available. Make sure the admitting team is aware of your concerns. When she wakes up, she can go into acute baclofen withdrawal. Like benzodiazepine withdrawal, it can be life-threatening. Within minutes of your tapping the baclofen reservoir, Amy's heart rate increases to the mid-90s and she's more arousable. You admit her to the pediatric intensive care unit and she slowly clears over 48 hours. It turns out, after the dust settled and a programmer was found later in the hospital course, Amy normally receives 620 micrograms per day. Due to the pump malfunction, she could have potentially received an additional 2,000 micrograms over the course of a few days. It finally caught up with her, and luckily you were there, ready to help out. Jimmy is a 12-year-old boy with dilated cardiomyopathy after a nasty bout of myocarditis last year. Initially, he had an ICD placed for ventricular dysrhythmias and had a diminished ejection fraction of 15%. But later he went on to decompensate and he was stabilized with an intra-aortic balloon pump and he received a ventricular assist device while awaiting heart transplant. He was managed well at home with his device until today. Jimmy has had nausea, vomiting, and diarrhea for the past few hours. His siblings probably brought something home from school recently. The whole family is suffering. He comes to you looking unwell, minimally interactive, and he only groans when you attempt to interact with him. His temperature is 38.1, heart rate on the monitor is 133, blood pressure 100/60, respiratory rate 22, O2 saturation 96%. You listen to his heart and hear a strange hum. What is this? It's not a rattle, it's more of a hum. Jimmy's LVAD is whirling along, powered by the centrifugal force of the magnetically elevated accelerator fan. He comes to you looking tired, and you start the rest of your assessment. Lungs are clear, but a bit coarse at the bases. He has good tidal volume, and you feel for the character of his pulse. And you feel for a pulse, and you feel some more, and you realize that this walking, talking, perfusing child is pulseless. Ventricular assist devices have come a long way. Not too long ago, they were bulky, powered by a large tympanic pump that would wear out prematurely and, due to its large size, was only implantable in older men. The next generation ventricular assist devices use continuous magnetic-powered pumps that are smaller, which pave the way for their use in smaller women and children. A ventricular assist device may be an LVAD, a left ventricular assist device, or an RVAD, a right ventricular assist device, or even a BiVAD, a biventricular assist device. VADs help patients with different goals. In adults, they may be a bridge to a transplant, a stopover until a donor heart is found. A VAD may be a bridge to candidacy in a patient in recovery for substance abuse who may qualify for a transplant later. In some adult patients who have no other options, the VAD itself may be a destination therapy. He may live the rest of his days powered by an external battery, or better said, by a battery and a perpetual backup battery. In children, it's more common to see VADs as a bridge to transplant, or in some cases in children with reversible damage like chemotherapy-induced cardiomyopathy or post-myocarditis syndrome, as a bridge to recovery. Regardless of the goal, the success of this technology is also the source of some real trepidation in the community. When there is an issue, they often go to their center where they receive their care, but if they're in extremis or out of town or just miss the off-ramp, they're coming to you. Luckily, there's a whole team that is highly invested in this patient. We're not going into this alone. He will have a nurse coordinator, a nurse practitioner, a cardiologist, a surgeon, an engineer, a social worker, even a dietitian. The key is to call the coordinator as soon as possible in the visit. Now, that's all well and good, but what do we need to know at the bedside? I mean, you got to be able to tell the coordinator something to work with, right? Or you have to know enough to do what you can so that you're able to leave the bedside long enough to make that phone call. Joe Bellezzo has a great way of evaluating his patients. I encourage you to look him up and to learn from him. So with a hat tip and apologies to Joe, I'll give you my take. With any child or adult who has a VAD, you should look, listen, feel, and call. First, look. Is the patient mentating? If so, chances are his perfusion is adequate. Look for bleeding. These guys are anticoagulated, of course, but they also can acquire a type of von Willebrand's deficiency due to the constant RBC trauma of the motor. Look also at the unit itself. The most downstream are the tandem batteries. Always one on, always another as a backup. What's the power level? If it's too low, does the patient have his adapter to plug into the wall? Does your hospital have an adapter? Getting closer to the patient and proximal to the battery is the controller box. Are there any error messages? Is it turned on? Patients with some cardiac function may survive with a powered off device, but don't go testing out that idea. Connecting the controller box to the patient is the drive line. the cable that enters the patient, usually in the right upper quadrant. Is it connected? Does it look infected? All right, we've looked for anything obvious. Now, let's listen. Listen for a continuous hum. The use of VADs in children is relatively recent, so none of them will have that first-generation pulsatile VAD. They'll all have the continuous flow VAD, powered either by centrifugal force or axial motor. The hum should be a pleasant, faint sound. If you hear irregular changes in the sound, basically it sounds like a failing hard drive, you should be concerned about a clot. Next, we feel. Feel for a pulse. Patients who have some preserved ejection fraction may actually have a pulse, but often it's not palpable. You measure perfusion really by mental status, by perfusion to the skin, and by screening for end organ function. The goal blood pressure is a mean arterial pressure. Use the manual cuff and bedside Doppler like you would measure an ankle brachial index, and not at what pressure you regain the whoosh. Just remember, instead of the familiar ABI triphasic whoosh, 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 you get whoosh. Note that MAP. Ideally, it's above 65 and below 90, regardless of the age. Feel the controller unit. If it's hot, it's working too hard. There's just too much power needed to drive the pump, probably because there's a clot in the pump and it's working hard against it. Finish your targeted brief H&P and relay all of that information to the coordinator. They are extremely knowledgeable and they will know your patient well. They should. The whole endeavor constitutes an investment the size of a small mortgage. Not to mention the time, care, and attention that the multidisciplinary team thoughtfully invests in this child. On bedside echo, you're going to be weirded out. The patient may appear to be in asystole. Focus on the chambers. If the RV is small and collapsible, give fluids. VADs love them some IV fluids. They are very preload dependent. If the RV is enlarged, consider pulmonary hypertension. Correct any hypoxia or acidosis. If both the RV and the LV are enlarged, there may be a clot that is backing everything up. Treat any arrhythmias you see, especially in an LVAD. They still need to run their RV to pump the lungs. Defibrillation is totally safe. Of course, if you have a BiVAD, then it won't matter as both pumps would be powering the heart. Jimmy is volume down, so he receives gentle IV fluids and he perks up. He's admitted for further observation and he continues to do well the next day. Hopefully you're never in this situation, but if he were to decompensate with a non-functional VAD or hypovolemic shock from a GI bleed, you can perform CPR. You may dislodge the circuit, but at that point, what else are you going to do? The brain needs to be perfused. Hopefully, neither of us is ever in that situation, but it's better to know our options now than to flounder later. Other complications of long-term VADs include infection, especially of the driveline, also stroke and hemolysis. In summary, the higher tech kid can be a handful. Here are 3 main points I'd like us to take away. 1. In vagus nerve stimulators, remember that you may prevent or abort a seizure by waving the magnet over the generator. If you want it to remain off, you can tape the magnet on the chest wall over the generator, and after 6 seconds, it'll turn off and remain off until you remove the magnet. 2. In intrathecal pumps, verify the medication and look for that toxidrome. You can evacuate the pump directly by using the template or palpating the dimple, or you can use ultrasound. Take off as much as you can. The pump will shut down when the level gets too low. And 3. In ventricular assist devices, remember to look, listen, feel, and most importantly, call. No pulse, no problem, but look for clinical perfusion and document a mean arterial pressure. If he arrests, treat him like anyone else. Thank you for listening. Until next time, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.